Today we'll be talking about pediatric nephrology. This is the recommended reading. It all comes from Nelson's Essential of Pediatrics. These are your objectives. There's a second slide on this as well. As you should know by now, all of my test questions come directly from these objectives. Occasionally, I put a little bit more information into my PowerPoints and my written materials because I think it's important information for you to know as a future physician and for board exams. This is a table from Nelson's that shows the primary and systemic causes of renal disease in children. We'll be going through the most important ones of these throughout this lecture. Let's start by giving a little bit of a background. Normal urine output. Kids are not just little adults. They are anatomically and physiologically different. So if we look at the normal urine output from birth to about 2 years of age, we expect about 1 cc or 1 milliliter of urine per kilogram per hour. Once they're older than 6, that drops to about 0.5 of a cc per kilogram per hour. We're looking at normal renal functioning. So just looking at the lab test, we can see creatinine tends to be lower in pediatric patients and then goes up to about the adult range over 1 year of age. And the GFR also is initially lower, and then we see that increases as the child gets older. So as the body size increases proportionally, the GFR remains stable. Let's start by talking about proteinuria. I have this picture here to show you what proteinuria looks like on a gross specimen. Anybody who is a home brewer may know that one of the things that we add to give beer its foaminess, its bubbles, is protein. And that is how we see protein in the urine as well. It's foamy. It gives some bubbles. So you can see that example there. Proteinuria is defined as a dipstick presence of greater than 1+ protein on 3 different urine dipsticks. Another way to define it is a 24-hour urine protein that's greater than 4 milligrams per meter squared per hour. Or another way to define it is a random urine protein to creatinine ratio of greater than 0.2. The way that we do a 24-hour urine protein is by literally collecting all the urine that a person makes in 24 hours. So as you can imagine, that can be fraught with inaccuracy if somebody's collecting it at home. They accidentally urinate somewhere outside, to miss capturing a urine, and then suddenly we're unable to make that measurement. So doing the protein to urine creatinine ratio in a one-time sample is much more feasible. Nephrotic range proteinuria is defined as greater than 40 milligrams per meter squared per hour, or a urine to protein creatinine ratio of greater than 3.5. So you can see that's significantly higher than just the urine protein to creatinine ratio of greater than 0.2, which is how we define proteinuria. So now let's look at how proteinuria presents. It's usually found incidentally, right? And it's important that we confirm that it's true proteinuria before we embark on further evaluation. So we may get a UA for some purpose or another, and suddenly we see that there's some protein in there. If it is not found incidentally, then we see patients with significant edema, which we can see here in these pictures. So we can see edema in kids, most commonly if it's due to proteinuria. We see really significant periorbital edema, so edema around their eyes. We can see that picture of this child here. She's got periorbital edema. She also has edema in her cheeks. We also tend to see scrotal edema. I feel like that is one of the most significant places. If you think of dependent portions of our body, so scrotal edema or labial edema, we'll see a lot in kids, as well as pedal edema, which is what we can see in that image with the A and the B, where they're actually showing the pitting edema. Hypertension, and hypertension is defined differently in pediatrics than it is in adults, right? We're not just using a cutoff of a specific number, but we're actually looking at where their blood pressure falls in terms of ranges, so greater than the 90th percentile per age and gender and height. We may see some ascites. We may see some pleural effusion. Most of the time it's incidental. If it's not, then usually they're brought in because of edema, and usually we find hypertensive on exam. So causes of proteinuria in pediatrics. There's transient proteinuria, which means that for one reason or another, the kidneys just released more protein into the urine than they normally would. This could be due to things like fever, exercise, trauma, surgery, or seizure. There's orthostatic proteinuria, which means that upon standing upright, the patient has proteinuria. One of the ways that we check for that is we ask them to collect their first morning void, and that first morning void, right after they've been laying flat all night, they get up and go straight to the bathroom and pee, and that first morning void doesn't have any protein in it. That tells us that they most likely have orthostatic proteinuria. Tubular disease like interstitial nephritis can lead to proteinuria, as can glomerular disease, right? So things that can lead to nephrotic syndrome, like minimal change disease, focal segmental glomerulosclerosis, and membranoproliferative glomerulonephritis. And we'll touch on these in a little bit. In gathering our history, we want to talk about maternal pregnancy complications and the child's birth history. We want to ask if they have noticed any edema, so ankles, abdomen, periorbital areas, genitalia. Any recent illnesses? Have they had things like impetigo or pharyngitis, right? So looking for that post-streptococcal glomerulonephritis. Do they have any joint pain or rashes that may give us a clue into other causes of proteinuria? Do they have a history of problems in their urinary tracts? So urinary tract infections, any urine abnormalities. I'll ask specifically if their urine has seemed more foamy or bubbly lately. Has their urine been more dark, Coca-Cola colored? Make us worry about hematuria. Do they have a history of hypertension? Have they lost weight or gained weight recently? So weight gain may be due to edema, to their body holding on more fluid than it normally would. Weight loss may be a sign of some other disease process, right? So could there be some sort of a tumor or other process? Is there any family history of renal disease? Any family history or personal history of diabetes? For physical exam, we're going to be checking their blood pressure. And remember, we measure this on charts based on the normal ranges of what we expect for the child's age, their gender, and their height percentile. We're going to be measuring their height and weight. We'll assess for edema, especially looking in the dependent areas. Check to see if that edema is pitting. We'll check their skin for any rashes or purpura. We'll do a joint exam, an abdominal exam, feeling for masses or any abnormalities, and a respiratory exam, listening for pleural effusions. Proteinuria, the dipstick urinalysis. You can see here the range on a dipstick. So this is when somebody leaves a urine sample, and then you just take one of these dipsticks and dip it into the urine and then wait to see what color it turns. It ranges from negative all the way up to 4+. And then, you know, the pluses, 1+, 2+, 3+, and 4+, that gives you kind of a general idea of about how much protein is in that urine sample. It's important that we compare it against the alkalinity and concentration of urine, because if the urine is very alkaline, that could give you a false negative. So it may seem like there's no protein in there when there really is. If their urine is very concentrated, that may give you a false positive. So if the kid is just dehydrated and needs to drink more fluid, that may actually give the appearance of them having, 2 or 3 plus protein on their dipstick, when in reality they don't have any. Labs and imaging. We'll be doing a urine analysis, of course. The urine protein to creatinine ratio, and that's going to be the one that we prefer over the 24-hour urine protein measurement, and that's just because it's easier, more feasible to do. Urine culture to see if there's any signs of infection. We may do some blood tests as well, so looking at the BUN and creatinine, electrolytes, their total protein and albumin, so are they losing too much protein, their cholesterol levels, their ANA, C3 levels, ASO titers, and a renal ultrasound. And this algorithm that you can see on the right-hand side of the slide is really what we use to help us decide at what point are we ordering which of these studies. And this algorithm is actually going to be continued on the next page. You can see from here we're going from asymptomatic proteinuria all the way down to the point where we're checking urine protein creatinine ratio. And then I'll flip to the next slide so you can see what we do next. So this is after we recheck the urine and then check that urine protein to creatinine ratio, and then what do we decide, right? If it's low enough, if there's no proteinuria, we don't need to do anything else. If it's moderately high, we're going to check that first morning void, looking for that orthostatic proteinuria. And then if it is in the nephrotic range, that's where we're going to order all of the studies, all of the lab studies, and a renal ultrasound to see if we can figure out exactly why they have nephrotic syndrome. So now we're going to go into specific causes of proteinuria in pediatric population. So we'll start with that orthostatic proteinuria. It's the most common cause of persistent proteinuria in kids and adolescents. So if we just detect asymptomatic proteinuria on a dipstick, the first thing we're going to do is have the kid come back in a week or so, maybe a few days, and then check it again, right? And if it continues to be consistent, then orthostatic proteinuria is one of the most common reasons for that. It's totally benign. The etiology is the protein excretion in an upright position returns to normal when the patient is lying flat. The presentation is usually adolescent males, and they're totally asymptomatic. If you hadn't ever checked their urine analysis, you would never know that they had protein in their urine. To diagnosis, we recheck their urine analysis with a first AM void. So we ask them as soon as you get up from laying down in bed all night, I want you to urinate in this sample cup and then bring it back to the lab so that we can check it. We compare that first AM void and afternoon urine protein to creatinine ratios. If the AM ratio is less than 0.2, but later in the afternoon it's greater than 0.2, then we have our diagnosis. The total urinary protein excretion is usually less than 1 gram a day, so it's not like they're spilling a significant amount of protein in their urine. Nephrotic syndrome. So the key features of nephrotic syndrome include proteinuria, and they're at that nephrotic range, right? So that means greater than 40 milligrams per meter squared per hour, or a urine protein to creatinine ratio of greater than 3.5. So they have proteinuria. Because they're spilling all of their proteins in their urine, this means that their protein levels in their blood are low. So they have hypoalbuminemia. So their albumin levels in their blood are less than 3 grams per deciliter. They also have hyperlipidemia and edema. So these are the things you need to memorize for nephrotic syndrome: proteinuria, hypoalbuminemia, hyperlipidemia, and edema. And the edema is because of that oncotic pressure, right? So we don't have enough protein in our blood, and so the liquid within our blood vessels gets pushed out into our cells, which is why we have edema, right? So we actually need that protein, we need that albumin in our blood in order to be able to bring the fluid into our blood vessels. So let's talk about some causes of nephrotic syndrome. Minimal change disease. It is the most common cause of nephrotic syndrome in kids. It usually presents ages 2 through 10 years. The clinical findings, these kids tend to have edema. Sometimes they'll have some hypertension, but that tends to be less common. They may or may not have some thrombosis. The pathophysiology is effacement of the foot processes, the podocytes. So it's something that you have to use an electron microscope in order to be able to see, but it's that foot process effacement that causes it. Their UA has nephrotic range proteinuria. They typically do not have hematuria. Their albumin levels are decreased. Their cholesterol levels are usually increased, right? So we're seeing all of those features of nephrotic syndrome, which is proteinuria, hypoalbuminemia, hyperlipidemia, and edema. So we're seeing all of those with minimal change disease. The treatment, we usually give systemic steroids. So typically it's oral prednisone for about 4 weeks, and then we do a steroid taper. Most completely resolve by 21 days, and that's it. And it's really nothing to worry about. If they have atypical features, so if they have significant hematuria, if they have significant hypertension, or if they don't respond to systemic steroids, then we're going to refer them to a nephrologist for a renal biopsy and see if maybe there's something else going on. The prognosis tends to be fantastic. It's something that can be treated by a pediatrician or a family medicine physician. Some patients may have intermittent relapses. Very rarely does it ever progress to anything as significant as renal failure. Moving on to focal segmental glomerulosclerosis. This presents similarly to minimal change disease, including the age range, right? So that 2 years to 10 years, except FSGS has hematuria. These patients do have that Coca-Cola colored or tea-colored urine. We consider this in a kid with presumed minimal change disease who does not improve after 3 weeks of steroids. So this is kind of the first thing that we think of, right? So initially we think, oh, it's most likely minimal change. They're presenting with all the nephrotic syndrome pictures, remember, which is edema, hypoalbuminemia, proteinuria, and dyslipidemia. So they're presenting with all of those. We think it's probably minimal change because that's most common in these kids ages 2 to 10 years. We start them on steroids, but now they don't get better. So now this is what we think. All right, then since that didn't work, it's probably FSGS. Let's send them to a pediatric nephrologist so that they can get a biopsy. The pathophysiology of FSGS is, as the name implies, sclerosis or scarring of portions of the glomerulus. It is typically idiopathic. It may be secondary to some disease process. So we see it in some patients that have sickle cell anemia. Vesicular-ureteral reflux may lead to some of it. It does require referral to pediatric nephrology. This is not something that I'll treat in the outpatient setting in my practice. FSGS can progress to renal failure, and so they need to be followed closely by pediatric nephrology. Here we can see the treatment of FSGS, depending on what type of FSGS you have, what treatment they may give. This isn't something I'm going to test you on because this is at the level of the pediatric nephrologist, but just in case you are interested in seeing what the treatment options are. We'll move on to membranoproliferative glomerulonephritis. Membranoproliferative glomerulonephritis is the most common cause of chronic glomerulonephritis in older children and adults, right? So remember, we can kind of everything most common. If we add enough variable factors in there, minimal change is the most common cause of nephrotic syndrome in kids. Membranoproliferative glomerulonephritis, most common cause of chronic glomerulonephritis in older kids and adults. Most commonly presents with nephrotic syndrome. It may present similarly to post-streptococcal glomerulonephritis. Some patients may simply have gross hematuria, so they can see blood in their urine, or asymptomatic proteinuria. Hypertension is common in these patients. In their labs, their renal function may be depressed, right? So that means their BUN and creatinine levels. And their C3 is going to stay low. If you compare that to post-streptococcal glomerulonephritis, initially C3 levels in patients with post-streptococcal glomerulonephritis, their C3 levels will be low, but those levels will increase up to normal after a few weeks. Whereas with membranoproliferative glomerulonephritis, the C3 levels stay low. So that's one of the ways we differentiate those two in case we don't get a renal biopsy for one reason or another. Membranoproliferative glomerulonephritis has a very poor prognosis. Most progress to renal failure. So we absolutely refer these patients to pediatric nephrology for further management. We'll move on to hematuria. So let's talk about hematuria in children. It is incredibly uncommon. We break it down into two different parts. Gross hematuria, when you can actually see a discoloration of the urine. So a sudden appearance of red or brown urine. Red suggests blood coming from the lower urinary tract. Brown suggests glomerular disease. If you think about the red blood cells that are probably leaking through, in a lower urinary tract issue, those red blood cells are probably going to be whole and maintain their color. Whereas if they have to squeeze through the glomerulus, they're probably going to get damaged, giving you more of that brown color. You want to look for associated flank or urethral pain, injury, or trauma. For microscopic hematuria, this is when the urine looks completely normal. It's far more common than gross hematuria in both kids and in adults. They may or may not have any symptoms. So they might have dysuria, which is pain upon urination. It's usually detected asymptomatically on screening. So for one reason or another, we get a urine analysis on a child and we happen to see that there's some blood in their urine. I have an inappropriate mnemonic for hematuria, and this is both causes of hematuria in adults and in kids. I'm not going to give the mnemonic in order because it is highly inappropriate, although I certainly found when I was sitting in your shoes, the more inappropriate the mnemonic, the better I remembered it. So I'm just going to list the general classifications and categories of hematuria, and you can rearrange them into an order so that the acronym makes sense to you, so that it's something that you can remember. So when we see hematuria, we want to think infection. So certainly something like urinary tract infection, bladder infection, pyelonephritis, those can all cause hematuria. Another thing to think about is trauma. So trauma to the urinary tract itself, saddle injuries, anything like that. The next one is tumor. So could it be bladder cancer? Could it be something like Wilms tumor, which is a tumor of the kidney itself? So some sort of tumor in the urinary tract. So infection, trauma, tumor, and then stones, nephrolithiasis. So those are all the kind of the big general categories you think of when we think about patients at hematuria. So the red-brown color in urine can be due to blood, right, or hemoglobin or myoglobin, or it could be due to another pigment, so from foods or medications. So one of the ways that we figure this out is we centrifuge it, we spin it around. If there is sediment and the sediment at the bottom is red or brown, then it's likely due to blood. If it's supernatant is red or brown, so if even after centrifuging we still have red or brown in the liquid portion, then it's most likely due to a pigment. So maybe they ate a bunch of beets or had a lot of dye in some of the foods or drinks that they recently had, then that's just what's coloring their urine. Hemoglobin and myoglobin will also give the supernatant, that red-brown color. So hematuria in kids, the positive dipstick. So once again, this is just a simple urine analysis. If it's positive, the red-brown urine might be due to blood, could be due to hemoglobin, could be due to myoglobin. And that's if the dipstick itself is positive. So here's a chart showing hematuria in kids. So could be hematuria itself, meaning blood in the urine, red blood cells, which we'll see on microscopic slide. Could be due to hemoglobin, could be due to myoglobin, or it could be due to a pigment. The pigment may be found in different medications like phenytoin, rifampin, nitrofurantoin, or it could be due to beets or other dyes in certain foods. So here is a way of differentiating where the blood is coming from. So if it's extraglomerular versus glomerular, right? So remember, we think lower urinary tract if the urine is bright red, so red or pink, or we think that it's coming from the glomerular area. If it's brown or tea colored, you might actually get some clots of those red blood cells for the lower urinary tract. The red blood cell shape is going to be normal in that instance. Whereas if it's coming from the glomerular level, the red blood cell shape may actually be dysmorphic because those red blood cells had to pass through that area. And then these are causes, right, of the non-glomerular hematuria, so UTI, local irritation, trauma, malignancy, Wilms tumor, hypercalciuria. We'll talk about those things, the things that are bolded. And then glomerular, post-streptococcal glomerulonephritis, IgA nephropathy, Alport syndrome, thin basement membrane disease. So when gathering the history, we'll ask about any trauma that they may have had. We'll ask about fever to figure out if they may have an infection. We'll ask if they have painful urination, so looking for infection or stones. Have they had any blurry vision or headaches, things that make us worry about some sort of a systemic problem? Do they have flank or abdominal pain? Any recent skin infection or pharyngitis that would make us think about post-streptococcal glomerulonephritis? Do they have edema, right? So also looking for proteinuria along with the hematuria, and any family history of anything that may be related: hematuria, kidney disease, kidney stones, bleeding disorders, rheumatologic disorders. Lupus nephritis can give you hematuria, so that's part of the reason why we're looking at joints, as well as asking some of these questions like fever. Physical examination, we're going to be looking at their blood pressure. We'll be doing a good fundoscopic exam, looking for hypertensive changes. We will be checking their abdomen to see if it's tender, right? So, you know, if they have a UTI, then there may be some tenderness, or if they have a stone, there may be some tenderness. Or are there any masses, something like Wilms tumor? Do they have CVA tenderness? So with infection, pyelonephritis. Look at genital exam for any signs of trauma, a really thorough skin examination to rule out some of the other causes, and edema. And then our labs and imaging. So once again, I have a portion of an algorithm up over on the right-hand side. The next slide is going to give you the second part of that algorithm. So if there has been trauma, we'll get a CT scan so that we can see exactly where the trauma is and what the extent was. If there are signs of a urinary tract infection, we'll do a urine culture. If there are signs of nephrolithiasis, right, so kidney stones, we'll get a renal ultrasound. Depending on what else is going on, we may get some blood work, including CBC, electrolytes and calcium levels, BUN creatinine. We may look at their serum protein and albumin, their cholesterol levels, C3 and C4, ASO titers, and ANA levels, and then that urine protein to creatinine ratio. Here's the second portion of that algorithm, so you can see at what point we decide to do further imaging and workup and what that is. So if a patient just has asymptomatic microscopic hematuria, so they didn't even know that they had hematuria, we just picked it up on a urine analysis, then we monitor. So we have them come back every 3 to 6 months. We check a urine analysis, we do an H&P, and we just keep doing that until the problem resolves, as long as they have normal blood pressure, normal renal functioning, a negative renal ultrasound, no significant proteinuria, and no other signs suggestive of disease. So we may just monitor these kids for even as long as a year or 2. The prognosis of hematuria: if they have gross hematuria, that's more often associated with significant renal disease. Most still have a good prognosis as long as we rapidly diagnose them and treat them. For microscopic hematuria, they have an excellent prognosis and recovery, especially if everything else is normal. They don't have a family history of any kidney problems. They've got a normal blood pressure, normal renal function, and no proteinuria. We'll go through some specific causes of proteinuria in kids, starting with thin basement membrane disease. This is also known as benign familial hematuria or idiopathic microscopic hematuria. So this has microscopic hematuria, meaning the patient doesn't see it themselves. There is no proteinuria. It's confirmed with a renal biopsy, but this isn't always necessary, right? We know that if a patient has microscopic hematuria and no other signs or symptoms, we're just going to keep monitoring them every 3 to 6 months. So that is the most common way that we handle thin basement membrane disease. Hypercalciuria is another cause of microscopic hematuria. So these patients have a urine calcium to creatinine ratio of greater than 0.2. I actually saw this pretty frequently in residency at the Children's Hospital. Patients would be referred to the pediatric nephrologist for persistent microscopic hematuria, and this would be one of the first tests that they would order. So it's a test I've learned to order as an outpatient pediatrician, a urine calcium to creatinine ratio. If it's greater than 0.2, we have our answer. It means that there's just more calcium in their urine than we would typically expect. The causes for that extra calcium in their urine, most of the time it's idiopathic. It could be due to things like hyperparathyroidism, furosemide use, or others. The important thing to note when you do diagnose a patient with hypercalciuria is that about 15% of patients with this will develop a renal stone within 5 years. You want to make sure you get a renal ultrasound to rule out nephrolithiasis or nephrocalcinosis. And the way that we manage hypercalciuria is we make sure that these kids are drinking plenty of fluids. And then if I were to diagnose this, I would refer them to a pediatric nephrologist so that they could follow them really closely and decide whether or not they may need a thiazide diuretic to help decrease the amount of calcium in their urine. Alport syndrome is another disorder with microscopic hematuria. These patients may have episodic gross hematuria. It's X-linked dominant, so it usually affects males. These patients have sensorineural hearing loss at about 4 to 5 years of age. About 50% have eye abnormalities, typically cataracts, and they may lead to progressive renal failure in teens to young adulthood. We refer these patients to pediatric nephrology. IgA nephropathy, also known as Berger disease. This is a spectrum of a disease that can range from asymptomatic persistent hematuria, which is the most common form of IgA nephropathy, all the way up to gross recurrent hematuria. That's usually right after an upper respiratory tract infection or physical exertion. And it can go all the way to nephrotic or nephritic syndromes with renal failure. You need a renal biopsy to diagnose definitively, and these patients have a variable prognosis depending on the persistence of their proteinuria. We once again refer them to pediatric nephrologists for their further treatment and care. Their treatment may involve general interventions to slow down the progression, monitoring their blood pressure control and making sure that's being controlled for, or they may have some immunosuppressants, typically glucocorticoids. Post-streptococcal glomerulonephritis. This typically occurs 1 to 3 weeks after a group A streptococcal infection, so typically strep throat. These patients present with a sudden onset of gross hematuria, edema, hypertension. Sometimes they have some renal insufficiency. We evaluate with an ASO titer. You can also use the DNase-B or streptozyme test, so some tests to see if they've had that recent group A strep infection. Their C3 levels will be low, but that should improve after 8 weeks. So after 2 months, their C3 levels should come back to normal. If their C3 levels remain low after 2 months, then we think about MPGN, which is something I talked about back in that section. Their C4 levels should be normal. This is in contrast with lupus nephritis, where C4 levels would be low. We treat with salt restriction, diuretics, and antihypertensives. The acute phase improves within 2 months, but urinary changes, that hematuria, it may persist for over a year. Early antibiotic therapy for group A strep infections does not eliminate the risk of post-streptococcal glomerulonephritis. That is the whole reason we give antibiotics, in order to prevent acute rheumatic fever to patients that have strep throat, but it unfortunately doesn't help to prevent post-streptococcal glomerulonephritis. And here we can see a picture showing the signs and symptoms, that edema, fever, the hypertension, blood and protein in their urine, and then we can see why it is happening. So typically those immune complexes from the strep pyogenes and the antibody complement that are affecting the glomerulus. And then finally, Wilms tumor. It represents nearly all renal tumors of childhood. The mean age of diagnosis is 3.5 years. My mnemonic for that is, if you take the W and turn it on its side, it looks like the number 3. So typically we see this at age 3. These patients present with significant abdominal or flank mass or swelling. They may have fever, hematuria, and hypertension as well. This is intrarenal in origin, so it's usually really easy to distinguish from neuroblastoma on imaging. Neuroblastoma is not coming from within the kidney. It is another abdominal mass in kids, and another abdominal tumor in kids. Neuroblastoma, while I'm talking about my mnemonics, if you turn that N on its side and try to guess what number that would look like, it looks like a 2. So neuroblastoma we tend to see more often in kids age 2. Wilms tumor is more often in kids age 3. Wilms tumor is within the kidney. Neuroblastoma is not inside the kidney at all. We need to refer these kids promptly to pediatric oncologists. They're going to do imaging to assess for any types of metastasis that may have happened. And then treatment typically includes nephrectomy with abdominal lymph node sampling, and that's usually followed by multi-agent chemotherapy. They may or may not need radiation for advanced local disease, so if it has metastasized or if the lymph nodes were involved. In summary, kids are not just little adults. Algorithms for evaluation of hematuria and proteinuria can help to simplify the diagnostic processes, but they still require clinical reasoning and excellent history and exam skills. You want to differentiate upper from lower tract hematuria and nephrotic range from non-nephrotic range proteinuria, as that's really what's driving our differentials. Repeat urine examinations, those urine analyses, they are inexpensive, really easy to do, and it can really help us with our diagnosis. And nephrologists are our friends. We should refer early. That's all I have for you. If you have any questions, please do not hesitate to contact me. Thank you so much. Have a great day.